Good morning to everybody from India, and good afternoon, good evening if you are from the rest of the world. Today, our guest speaker is Dr. Ashish Bajal from Melbourne, Australia, and he's going to lecture us on optimizing the treatment of Ph+ve acute lymphoblastic leukemia. You all agree that once a deadly disease not getting cured even with allotransplant, TKIs and the immunotherapies have changed the whole scenario. It has made things good, but also one has to now think how to optimally treat these patients. So that's the title of this talk, Optimizing the Treatment. And we're going to learn a lot from Ashish Bajal today. This webinar is brought to you as usual, Mumbai Hematology Group. This one is supported by Unipath, NATCO, and Lucian. As usual, Perfect Square is managing these shows. So I'm grateful to Unipath, NATCO, Lucian for supporting, Yash, Kalpesh, and the team Perfect Square for managing, Executive Committee of MHG for their permission, and our guest speaker, our chief guest today, Dr. Chetan Damne, whom I will soon introduce to you. Our guest speaker, Dr. Ashish Bajal from Melbourne, and he has spoken to us now at many occasions. Grateful to him. All our discussants, you have been absolutely the live wire of these webinars. So we have a galaxy of hematologists and hemato-oncologists from India and nearby countries, and all other participants who have been sparing their Saturday evening, Sunday morning, and so on to listen to the academics. Next weekend, we don't have webinars. We have the annual conference, the 49th one, the annual conference of Mumbai Hematology Group, Saturday, Sunday, Monday. 100 faculty from Mumbai, 100 faculty from all over the country, and 8 international faculty. 4 parallel halls, morning to evening. So there is full of academics for all of you. If you have not yet registered or not decided to come, please come over. Our discussants today, names are displayed here alphabetically. They are virtually who is who, and they're going to interact with our speaker, Dr. Ashish Bajal. So just briefly introducing Dr. Ashish Bajal for those who have logged in for the first time today. He's associate professor, consultant hematologist, and transplant physician, disease group co-lead, acute leukemia and myelodysplastic syndrome, Peter MacCallum Cancer Centre, Royal Melbourne Hospital, Melbourne. He graduated from University of Mumbai, India, followed by specialist training in internal medicine and hematology, culminating in a DM clinical hematology. Subsequently obtained fellowships of the Royal Australian College of Physicians and Pathologists in clinical and lab hematology. He is actively involved in clinical research as a principal investigator and associate investigator of clinical trials focused on novel drug and cellular therapies in acute leukemia and alternate donor transplants. He's a peer reviewer for multiple hematology journals and associate editor for the journal Transplantation. He's on the board of directors of the Australian Transplant and Cellular Therapy Society. And as I mentioned earlier, he'll be speaking to us on the treatment of Ph+-positive acute lymphoblastic leukemia. Before he does that, we have our special guest today. And that is none other than Dr. Chetan Damne from Mumbai itself. You all know him extremely well. He is professor, pediatric oncology at the prestigious Tata Memorial Hospital, Mumbai. He completed his MBBS from Mahatma Gandhi Institute of Medical Sciences, Sevagram, Varda. This was followed by pediatric training from Cook County Hospital, Chicago. Because of his interest in research, he went to Penn State, Hershey, and completed a master's in integrative biosciences. This is fantastic. Subsequently, he joined MD Anderson in Houston for his fellowship in pediatric hematology oncology. During his training, he was inspired by his mentor, Dr. Lawrence Cooper, and got interested in cellular therapies. He moved to the National University Hospital in Singapore, where he worked as a consultant and was involved in NK cell trials for AML and neuroblastoma with Dr. Dario Campana. After his return to India, he joined Tata Memorial Hospital and he continues to work in that institute on cell-based therapies till date. In collaboration with Dr. Hassan at Attract, the team has developed cytokine-induced memory-like NK cells for acute myeloblastic leukemia. And that's again fantastic. He's also working on other cell-based therapies that are in early preclinical development. He's interested in applying technologies to solve the challenges in pediatric leukemias. With the data manager team at TMH, he has developed an app to track maintenance therapy for outstation children with ALL, the third fantastic part of his career. Dr. Chetan is interested in newer therapies for AML and is working on the AML registry for pediatric AML. So this is a brief of his biosketch, which is very long one. We just cut it down just in the interest of time. And now it's time for him to inaugurate this webinar and give some word of wisdom, not only for the juniors, and also for all of us. Yes, Chetan.
Thank you, sir. That was a very generous introduction, and I'm privileged to be a part of MHG. I have been associated with MHG since I have come to India, and I have seen the way the seminars are conducted. Everything aside, whatever happens, Sunday morning, Saturday evening, there is an education session, and we have the MHG annual sessions plus additional sessions that we have when there are guest speakers. So I am really inspired by Dr. M.B. Agarwal, the way he conducts these sessions, not only for education of other consultants, but also for the juniors. So it is a great opportunity. I think not all the places that I have been to, none of the places offered this opportunity to me. So I'm very privileged. He has invited me as a chief guest, but I'm sure there are many more prestigious or honored faculty who are present in the audience. And one message that Dr. Agarwal has asked me to tell you, and I would say that I just ran the Mumbai half marathon today, and even that is pale in front of Dr. Agarwal's enthusiasm, and he is so active that even if I send an email to him at 3 a.m., the reply is within an hour, he will reply. And during the day, it is just so fast, in spite of having such a busy clinical service that he runs all across Mumbai. So what I would like to encourage all the juniors is to focus on what you're doing, and that will keep you active. If you do well and do your job sincerely, there'll be many people who will always support you, encourage you, and you will always be successful. So don't think of success first, focus on what you're doing, and that will be the game changer for your life. You will not have to think of anything else. With that, I would like to thank Dr. Agarwal once more, and would like to him to start the session.
Well, thank you, Chetan. First of all, kudos for the half marathon which you ran and have come and joined us for giving this little brief speech. Wonderful, wonderful.
Thank you, sir.
Your words were great inspiration. I'm sure a lot of our colleagues and students who have listened to you today will follow this advice. I have one advice from my side. Listen to your insight. Do what gives you joy. And that is the success. So if something which you are doing by pressure, if it is not enjoyable, well, it's difficult to succeed in that. So now let's have some medicine. Go to Ashish Bajal for Ph positive ALL. Yes, Ashish.
Thank you, Dr. Agarwal. I call Dr. Agarwal sir because one thing he probably didn't mention was the reason I became a hematologist was because of Professor Agarwal. He inspired me, and I should agree with Dr. Chetan, Professor Chetan Ramnet, that his enthusiasm when I was a registrar is exactly the same as his enthusiasm today. So the drive is phenomenal, and we can all see that. So thank you for having me, and thanks for Professor Chetan for his inspiring words, and congratulations to him for his half marathon. So my job today is to speak on optimizing treatment for Philadelphia positive ALL. I hope you can see my slides in presenter mode.
Yes.
Those are my disclosures, and a bit of background. we have always known Ph positive ALL, and the most recent WHO iteration, it is B-cell lymphoblastic leukemia, lymphoma, characterized by the characteristic T920 translocation and the BCR-ABL fusion gene. Its incidence in pediatric ALLs is around 2 to 5%, but the incidence in adult ALLs is 25%. But in the sixth decade, it almost goes up to 50%. As we now understand Ph positive ALL, there are two different entities, and the reason I'm highlighting this is now becoming a bit important for us as we treat Ph positive ALL. There's a lymphoid only variant of Ph positive ALL, but we now have started recognizing, or we now know there's also a multi-lineage variant of Ph positive ALL. And this has got bearings on how we monitor the disease, because the mutation here is in the multipotent progenitor cell. Commonly, the Ph positive ALL has got a common ALL phenotype, but also has co-expression of myeloid antigens and markers. And as Professor Agarwal rightly said, tyrosine kinase inhibitors has phenomenally changed the prognosis of a disease that was always destined to allogeneic stem cell transplant, and a high proportion of patients still relapse. And immunotherapy has further bettered that prognosis, but it has raised some questions, and that's what we are going to be addressing in today's talk. So if I was to schematically present, and this is how my institution, before we had immunotherapy for ALL upfront, was addressing the paradigm of AYA in adult ALL. Newly diagnosed patients were getting a pediatric inspired or hyper-CVAD based treatment. And when they were MRD positive, at least the B cell ones were getting blinatumomab, moving towards a transplant. The high risk ones were dedicated towards a transplant. And then we had options for relapsed refractory ALL. What has changed? First, we've got better potent TKIs coming in. So we've got the second and the third generation TKIs. And the focus of today's discussion is going to be a bit on the third generation TKIs, mainly ponatinib. We have got blinatumomab, which has now been established in upfront treatment. The E1910 did it for the Ph negative BALs, but the DALBA study did it for the Ph positive ALs. What more has changed? The way we analyze MRD has changed, and while for Ph negative ALL, we have been using flow for a long term, we have been using ASO-PCRs with a sensitivity of 10 raised to -4. We now have the ability to use NGS, which has the ability of going to 10 raised to -6. Though in a BCR, in Ph positive ALL, we've got a much consistent biomarker. So that's going to be the focus of today's discussion. And the changes in Ph positive ALL have now raised a few questions for us. And the talk today that I'm going to do is going to focus mainly on upfront treatment, which is the better TKI to use. What's the backbone of our treatment? And if chemotherapy was the backbone, should it still be the backbone? And if it has to be the backbone, how much or how little? What's the role of immunotherapy? And this is becoming almost the gold standard of treatment for Ph positive ALL. How do we best address and mitigate the risk of CNS relapses or recurrences by optimizing the CNS-directed therapy? How do we best monitor our patients? And is the role of allogeneic stem cell transplant in Ph positive ALL, where it was given that patients who are fit would move towards a transplant, is that role evolving? So these are some of the questions that I plan to tackle during my talk. And I'll start off with the question of the tyrosine kinase inhibitors. And the first study that probably, or the most randomized data, comes from the Falcon study. And this was published in JAMA, where the question that they asked is, do you use a more potent TKI, ponatinib? Is it superior to imatinib when you're combining it with reduced intensity chemotherapy in adult patients? Was a 2:1 randomization. 245 patients got ponatinib plus low-dose chemotherapy, and 154 patients got that, and 78 patients got imatinib, which was the comparator arm. The imatinib dose was 600 milligrams. Ponatinib started at 30 milligrams, and then once the patients were MRD negative, they reduced the ponatinib to 15 milligrams, which is how we understand is the better way to use the drug to probably reduce the vascular toxicities that these drugs can cause. The primary outcome was the MRD negative complete remission based on the BCR-ABL PCRs that these patients achieved, and the complete remission maintained for at least 4 weeks. And if you look at the MRD negative complete remission itself, you can see that with ponatinib, twice the number of patients achieved a MRD negative remission. In the subsequent slides, I will show the differences that they saw in the event-free survival and the progression-free survival and the overall survival also. So a statistically significant difference in the primary endpoint was noted. We try to break this down. You can look at the MRD negative complete remissions at the end of induction. Again, as I said, are twice that in imatinib. You look at the MR4, which is you're setting the bar a bit lower. But again, when you're looking at MR4, consistently double the number of patients with ponatinib got MR4 response. And again, the loss of response was much lower in the patients who were treated with ponatinib as compared to the patients who were treated with imatinib. The median duration of response was not evaluable in ponatinib, but was 18 months in imatinib. So clearly on a randomized trial showing that ponatinib is a much potent drug. Now, I've not shown the side effects or the toxicities, but these are usual expected side effects or toxicities, but they did not see a high incidence of vascular toxicities because they used at a lower dose of 30 milligram and quickly dropped the dose to 15 milligram and that was based on the prior MD Anderson data where they found a lot of vascular toxicities when they tried to use higher doses. If you look at the survival, and these are the Kaplan-Meier curves, looking at the median event-free survival, looking at the progression-free survival and the overall survival, in the experimental arm where they got ponatinib, this was not evaluated, was not reached, and was significantly superior to what was achieved by imatinib and chemotherapy. So probably giving us irrefutable data that you use a potent TKI, a third-generation TKI, it is clearly superior to imatinib. Now, there have been other subsequent trials that I'm going to show that data was not shared in the meeting, but clearly they showed the data with the ponatinib chemotherapy and imatinib chemotherapy. They haven't shown the survival data, but they could again clearly show that there was a significant improvement in the group of patients achieving a molecular response when ponatinib was the TKI of reference that was used as compared to imatinib. What about dasatinib? Now, the reason I'm putting dasatinib is I work in a health system that's reimbursed, and we do not have access yet to ponatinib as frontline agent, and so we are using dasatinib. And there is no randomized data with dasatinib that's available, and the best data is there either in the pediatric studies, that is the COG studies, or I elected to put this small study from MD Anderson by Farhad Rawandi, where they looked at the hyper-CVAS-based treatment, used dasatinib. The median age of the patient was 44, and again, you can look at the relapse-free survivals, and the overall survivals are pretty good. What came across in the study was you could use dasatinib, you could use chemotherapy, but when they did a landmark analysis, the patients who had allogeneic transplant, and this is the curve that is in blue on the top, their survival was superior, both the relapse-free survival and the overall survival, when the landmark survival at 175 days was done. So dasatinib chemotherapy, yes, but perhaps a role of transplant, and we will get into this issue a bit more about transplant as we move forward. So the other reason I've raised the question of dasatinib was this very interesting data that's been presented in the ASH last year, and this is again from the GMMA group. They had the D-ALBA study where they had patients with dasatinib and blinatumomab, and they now had the more recent GMMA study, which I'll be showing and sharing the data on, where they used ponatinib and blinatumomab. And this is them doing some immunological work on that, and they looked at the host immune modulation, and clearly you can see that when they look at the NK cells, the NKT cells, and there were subsequent slides shown on the Treg cells, dasatinib seems to be left with higher numbers. So when you look at the immunomodulation, dasatinib does a much more positive immunomodulation as compared to ponatinib. We don't have a head-to-head comparison between dasatinib and ponatinib. We have two different trials, and we can look at the data. But this is one reason that we still think that dasatinib definitely has got a role. So clearly, imatinib is inferior. Ponatinib is superior to imatinib. But if you cannot access ponatinib, then dasatinib has a good biological rationale to be used as the upfront TKI. So which TKI? My thoughts are the second or the third generation TKI, and the second generation is dasatinib. There is some data on nilotinib, and that data is of Korea, but in Australia, it's not reimbursed for upfront treatment for Ph+-positive ALL. Of course, one has to consider the comorbidities of the patient. We would like to use ponatinib as the more potent TKI, but if the patient has got significant vascular comorbidities, perhaps it's not a safe drug for them to be used, especially because the exposure to TKI for Ph+-positive ALL is now for a really long time. All right. So now moving to the next question, where is the role of chemotherapy? And as we said, the chemotherapy was the backbone for a Ph+-positive ALL. And this is a whole host of trials which use intensive chemotherapy and TKI. Of course, the patients got an excellent hematological response, but you can see that a large proportion of patients still went to transplant, and you can see almost 50% of these patients on trial, if not higher. Some trials had higher, 87% of the patients went to transplant to achieve these responses. So intensive chemotherapy, TKI, transplant, it's difficult to dissect whether intensive chemotherapy is still required. But what about when we look at low intensity chemotherapies? And this is data looking at low intensity chemotherapies and TKI. And this is data now showing that, again, these patients achieve a good hematological response. They still are requiring transplants, though albeit the proportion of transplants is dropping off when TKI and low intensity chemotherapy, and you've got a reasonable response. And then we have moved to the era where perhaps, and this was a lot of this work was done in older patients where chemotherapy was completely dropped off and they relied on imatinib, dasatinib, or ponatinib, use steroids. This is olverembatinib, which is a relatively new TKI. It's a third generation TKI and it's undergoing trials right now. Asciminib, we know is a STAMP inhibitor, is also, and with dasatinib. So again, it was possible to use a potent TKI, drop off the chemotherapy, and still achieve excellent survivals in a patient. But transplant still remains a part of some of these treatments. So the best study to think about chemotherapy and the intensity of chemotherapy is perhaps a graph study. And this is an older study. This was done by the French. They used what in arm A, a low intensity chemotherapy plus imatinib, and then they used in arm B hyper-CVAD and imatinib. Now, this study was designed in such a way that the patients were destined to have an allogeneic stem cell transplant. And so patients, once they had a molecular response, they had allogeneic transplant. But if you look at the survival curves, just by dropping the intensity of the chemotherapy, you did not drop off the overall survival of the patient. So perhaps there is no need to expose patients to that intensity of chemotherapy or those chemotherapy-based side effects. A lower intensity of treatment will be possible to be used in most patients. And as we enter the immunotherapy era, we will probably then start challenging whether even low intensity chemotherapy is still required in our patients or not. So the role of systemic chemotherapy would be fair to say that is significantly reduced. The question that most of us are asking is there any role of systemic chemotherapy? And subsequently in the talk, I have got some slides to contemplate on this as to whether the role is completely out at this point of time. So that's the second question that we address. And now the most important question, or the next game changer, the biggest game changer, and that's been the addition of immunotherapy. And we are all familiar with blinatumomab. It's anti-CD19, CD3 BiTE. In one way, it causes a bit of speed dating between the immune T cells and the leukemia cell, and results in the killing of the CD19 positive leukemic cells. It's a drug that's given by continuous infusion, which requires a lot of resources and becomes logistically a bit challenging. Is a 4-week on, 2-week off phenomena going on. There are efforts of a subcut blin, which has gone through the phase 1, phase 2, and is probably going to come in, is going through phase 2 and is going to come in a phase 3 study, which can be delivered weekly after you give an initial loading. And there are also other drugs which are coming as CD19, which are as continuous, which are infusional drugs given by intravenous infusion, but don't have to come via continuous infusion. So there is a CD19 antibody or BiTE coming from AstraZeneca, and there's another one with MSD, which are looking at fortnightly infusions over a short period of time, which are less cumbersome as giving blinatumomab. But the data is, because the gold standard drug has been blinatumomab, the data is the blinatumomab. Now, earlier on, we knew blinatumomab could be used for refractory Ph+-positive ALL, and the data was from the Alcantara study. It's a single-phase study where patients who had exposure to TKI chemotherapy relapsed, CD19 expressing, were given blinatumomab, single-arm study, small study, but they could clearly show that 36% of the patients with blinatumomab could achieve that remission in a Ph+-positive ALL. So that formed the basis of blinatumomab becoming approved for relapsed refractory Ph+-positive ALL. And in most common situations, not only do we change the TKI, but we were adding blinatumomab in a relapsed refractory situation. But what about blinatumomab in the upfront situation? And this data is from the DIALVA study, which was the frontline study that Jim ran, a single-arm study. And it's a no chemotherapy-based study. So they used steroid pre-treatment and then used dasatinib and steroids and went up to day 35, looked for a hematological response. Patients had a hematological response, they would go into blinatumomab, and they then evaluated a molecular evaluation after 2 cycles of blinatumomab. Patients could get up to 5 cycles of blinatumomab, and they combined with dasatinib. They used a dose of 140 milligrams of dasatinib. Now that's a higher dose, but when patients were not tolerating it, they dropped it to 100 milligrams. Patients who were not in complete remission also went on to blinatumomab, but at the same time, but they dropped the dasatinib because these patients had been adequately exposed to dasatinib and hadn't responded. Now, complete molecular responses rates, when you look at the day 85, when they were actually just exposed to dasatinib and steroids, are not very high. 10% of the patients got a response. After the first cycle of blinatumomab, it increased to 35%. Now, the patients, one of the things in the trial that they did was that patients who had a Icaros plus gene signature were deemed high risk. Patients who were persistently MRD positive after blin were deemed high risk, and all those patients went towards transplant. Now, and they were right because these patients who were Icaros plus, their disease-free survival was still inferior. The initial data was published in 2020, but more recently, a more mature follow-up at 53 months has been published. And you look at the overall disease-free survival, we said on the Icaros plus it was 44%, but on the overall group it was 75%. The overall survival was 80%. And again, you look at the end of induction and then the exposure of blin, the curves are moving because blin improved the curves which were in red at the bottom where patients had achieved a molecular response. After exposure to blin, the curves moved in upwards in terms of the survival. So blin improved the survival of those patients who are not achieving a molecular response just after dasatinib. Now, this was a 63 patients trial. 59 patients are eventually treated. Some patients relapsed with blin and some patients during the TKI. But I would like to point out that the proportion of patients who underwent allogeneic stem cell transplant was relatively high. So 38% of the patients in the first hematological response went into transplant, and then some patients in the second hematological response, that is 10%. So we are talking cumulatively of 48% of the patients in the DALBA study had a transplant, and nearly 38% had a upfront transplant. Now, the genomics clearly played a role. If you had no Icaros signature, or if you were just Icaros signature alone, your survivals were superior. But if you had Icaros plus signature, that is, you had Icaros Icaros gene deletion, plus you either had a PAX5 or you had a CDKNA2A or a 2B deletion, your survival was inferior. Now, transplant did, to some extent, improve or get the curves close together, but could not completely mitigate the risk. So that was the DALBA study. Now, the Genoma group went and did the ALL 282 study. This is the follow-on study from the DALBA. They changed the dasatinib to ponatinib. They had seen late CNS relapses in the DALBA study. They increased the intrathecals, and they gave triple intrathecals from 12 to 15. This was a randomized study, and the initial cut of the data was actually presented in ASH 2024, where they presented only the data of the ponatinib blin arm. Patients similar to the DALBA study got ponatinib, and then up to day 70, and then they started getting exposure to blin and ponatinib. And 151 patients were treated. The event-free survival was the primary endpoint in this group. And this is just from ASH 2024. I will show what was presented in ASH 2025. Of course, they had 32% of the patients who had the Icaros plus alteration gene. If you look at the table on the bottom and compare across, ideally we shouldn't be comparing apples to oranges. We are comparing patients across 2 different trials. But if I take a snapshot of what happened on the DALBA overall response and on this trial, you use a potent TKI. Your responses at the end of induction go up to 46% compared to 29% here, and after blinatumomab go to 74% as compared to 60%. So ponatinib is going to push up. That's the closest comparison that we are going to get between dasatinib and ponatinib. We don't have a single randomized trial to tell us that. They also started seeing a signal that apart from the Icaros signature, the white cell count representation had a bit of bearing on the molecular response. So if you had a really high white cell count, your chances of achieving a molecular response after blin was a bit low. And this is going to become important as we start thinking of which patient should have allogeneic transplant if we are going to start moving to this strategy. This was the first cut of the data, ASH 2024. The follow-up relatively short. They had 4 relapses, and they still had one patient with CNS relapse. At this point, 11% of the patients had a transplant, and for the same reasons, MRD persistent, across plus signature, or either both. Now, the other study that has been presenting the ponatinib blin data has been the MD Anderson single arm study, and this study differed a bit. This study differed a bit because they used the blin upfront. So they didn't wait for 70 days or 80 days to get a hematological response. They came up with 30 milligrams of ponatinib upfront blin here. As soon as the patients hit that molecular response, dropped them to 15 milligrams, and then continued the ponatinib 15 milligram for 5 years. Now, this is important to remember that the maintenance phase that in the trial they are saying 5 years, but if you speak to them, they really like to keep the patients going on and would not like to stop. If you speak to the D-ALBA investigators, that is their philosophy also, that the patients who did not have a transplant, if they had no reason to stop the TKI, they would keep going with the TKI. They increased the intrathecals based on the 15 quite low, quite is just 2, so it's probably less than 10% of the patients. But the thing that caught my eye was they were still seeing, despite those 15 intrathecals, were seeing at least a signal of CNS relapse going on. Interestingly, in their multivariate analysis, they still found a white cell count, which was higher at presentation, was the factor that was independently predictive of relapse. So there's a bit of signal building between the two studies that the white cell presenting count is reflecting something in the biology and maybe something that we have to account for as we plan treatments for these patients. They did not find the across plus signature in their multivariate analysis. Now again, a different set of patients, but they did not find that as a prognostic factor. Now, we move to the GMMR study, which was presented in the recent ASH in 2025. And this is where they presented more mature follow-up with a follow-up of nearly 2 years. And they presented both the cohorts, not only the ponatinib blend, but they also presented the imatinib and the chemotherapy. Now, this is the schema of the study. The 2:1 randomization, as I said. They adjusted the dose of ponatinib for the older patients. So they went to 30 milligrams. The control arm was chemotherapy plus imatinib. Again, blinatumomab, again with ponatinib here. An interesting thing to note was they allowed a crossover. So if patients did not really hit the complete hematological response or were MRD positive beyond the primary endpoint, they did allow a crossover taking place in these patients. Who did they transplant? Patients who were MRD positive persistently, who had ABL mutations, who had genomic additional lesions, and by this they refer to the Icaros plus signatures. Those patients were the ones that actually went to an allogeneic transplant. IT therapies was 15, if CNS disease 18. Compare the two groups. The median age is comparable. Equal proportion of 28, 1/3 patients, more older group of patients. They tried that 10% of the patients had the higher white cell count. 10% in the experimental and 15% in the control arm had CNS disease. And again, they're seeing the 1/3 incidence of across plus signature in the patients. If you look at the molecular responses and compare it between the experimental and the control arm, you can see at the end of induction, it doesn't vary. But if you go at the blend cycles, it's still 29% here, 51% here. But if you look at this is the no molecular responses. So you had low no molecular responses when they used blend. And conversely, what I should have shown was the incidence of complete molecular responses is high the moment you use blend as compared to chemotherapy. So it's 52% versus 37%. Overall molecular responses after the cycles of blend, again 70% here and 48% here. So we are seeing that there is a clear increase. On the side, they put the D-ALBA, and again, you can see there's a difference between the D-ALBA that you're still getting higher molecular responses when you're using ponatinib in your patients as compared to dasatinib. We look at the event-free survival, significantly superior event-free survival of 90% in the ponatinib arm versus the imatinib arm. That's the ponatinib blend. And again, if you look at the overall survival, impressive 94% overall survival in the ponatinib blend arm. Interestingly, in the crossover arm, which is the gray curve on the top here, 97% of the patients still had overall survival. So I think we don't lose. So, and this is important for us who do not have access to ponatinib and blend. Even if we cannot get it upfront, we should certainly endeavor to try to get our patients based on this crossover data to ponatinib and blend if they are not getting the molecular response. Now, we look at the relapses and we look at the depth. The median time to relapse, interestingly, in the experimental arm is shorter as compared to the control arm. You see the high white cell counts are more prone to getting relapses. You got the signature, across plus signature here. The causes of death, again, are comparable and a lower incidence of deaths in the experimental arm as compared to the control arm. So it would be fair to say that blend plus TKI is the new gold standard. How do you get your, this is more of a consolidative strategy, I would say. This is, you get your patient into remission. Now, whether you use a TKI prednisolone alone, you use TKI chemotherapy to get your patient in remission, but there is a role clearly of then consolidating the patients with blend plus TKI rather than giving them repeated chemotherapy. The question whether chemotherapy is completely out still remains to be answered, and we will touch on that. All right. So we are getting to that question of CNS-directed therapy, and this is the question that I want to address. So this is data from a lot of trials that have used TKI and blend, and there is on the bottom there is data on trials that have used chemo and a bit of dasatinib. A lot of these trials have used low-intensity chemo, except it's going to be the hyper-CVAD chemotherapy. Now, unfortunately, in this one, which has got the most intense chemotherapy, they did not report the proportion of extramedullary relapses. But if you look at the D-ALBA, 5 patients had extramedullary relapse. That is, of the total relapses, 55% of the patients had extramedullary relapse. When you look at this American study, which had a small number of patients, they had 7 relapses, and again, 30% of the patients had extramedullary relapse. And in most cases, when they're talking of extramedullary relapses, they are talking of CNS relapses. Ponatinib plus blend, again, you have 71% of the total relapses had an isolated CNS relapse. So the signal doesn't seem to be going away when you're using TKI blend and when you're using a no chemotherapy strategy. Of course, if you're going to use just blend and TKI, and that's your protocol, then at least minimum 15 intrathecals are required. My institution does not do triples. We do single drug this. So we have incorporated 15 intrathecals. But the question that I would still ask is systemic therapy completely out? And when I discuss what we do in my institution, I'm going to allude to this point about whether we still should be using a bit of CNS penetrating chemotherapy to completely mitigate that risk. Most of us who have dealt with isolated CNS relapses know it can become a nuisance. It just doesn't seem to go away, and it's difficult to get on the top of it. So if rather than completely throwing the chemotherapy out, if we expose our fit patients to 1 or 2 cycles of CNS penetrating chemotherapy, we perhaps can completely mitigate the risk. Now, ideally, you need a randomized study to address the question, but this is the best data we have on person at this point. All right. So we moved through the treatment, and now is more about actually monitoring the disease. And I spoke a bit about MRD thresholds, and that has at least started changing the paradigm in Ph negative, but what about Ph positive ALL? And is BCR-ABL PCR is good enough, qPCR is good enough, or are there situations that we need a next generation sequencing? Now, as you know, in the next generation sequencing, you need to do a baseline sampling on your patient to identify the IGH clones. And then you find the most dominant clones and you can track those clones. And this is very early data from the German group. And now this is Ph negative ALL data that showed that when the Germans, the GMAL group was using an ASO PCR, and based on the ASO PCR, they did find some patients which were molecularly non-evaluable. That means they could see a positive signal, but they could not really quantitate it. And this is data from the GMAL when they applied an NGS to these patients who were molecularly non-evaluable. They could segregate that in a group that was NGS MRD negative, which clearly had a superior outcome or a survival as compared to the group that was molecularly non-evaluable but was NGS MRD positive. And we are talking of a sensitivity of 10 raised to minus 6. ASO PCRs can go up to 10 raised to minus 5, but don't really go up to 10 raised to minus 6. So this is a data from the GMAL group. Now, this data or this kind of findings has been replicated by MD Anderson. They in fact did this with multi-parameter flow cytometry, again with sensitive multi-parameter flow cytometries. We see we can reach a sensitivity of 10⁻⁵. There are some claims it can go to 10⁻⁶, but the best sensitivity usually is 10⁻⁵. And again, you can see that, and especially I would like to point you out to this curve on the right here, that if you have MRD negative by multi-parameter flow cytometry and negative by NGS at CR, your survival is superior. If you have MRD positivity by flow cytometry and NGS, survival is inferior. What about the group that is negative by flow cytometry, which is this red line here, but positive by NGS? And you see that they are not exactly sitting in the top group here. Their survival is somewhere intermediate. So you apply a more sensitive test, and again, this is Ph negative ALL. There was a very small proportion of Ph positive ALL. So you apply this very sensitive test platform and drop your MRD threshold. Perhaps you can identify patients who are at risk of relapsing. How does this hold with transplants? And this is data from Stanford, where they looked at next generation sequencing in patients undergoing allogeneic stem cell transplant. And they looked at it pre and post. So even pre-MRD, if you're going into transplant, you've got undetectable, your risk is lowest. Depending on how strongly positive the MRD is, your risk keeps on going higher. If you are post-transplant MRD positive on a sensitivity of 10⁻⁶ on NGS, your risk of relapse is very high. Again, a lot of proportion of patients in this was Ph negative, but there was small spattering of patients who were Ph positive also. So why am I discussing about this in a Ph positive talk? And the reason I'm discussing this in a Ph positive talk is there's another use of NGS that we have started understanding. And that is in patients who got this the Ph positive ALL, which has the mutation in the multilineage or the multipotent progenitor cells. And these patients, we realize that they run a very low level of BCR-ABL positivity, really never become negative. And again, this is two different studies showing that if you do NGS on these patients, then you can distinguish out the patients who are truly positive and the patients who are the multilineage. The multilineage patients who are in a true CR would essentially be up here. They would become NGS negative. They don't have those clones, and their survival is superior. So they may perhaps don't need to undergo a transplant as compared to this inferior group, which is positive on BCR-ABL and positive on NGS and should be considered for transplant. That data again was done by MD Anderson, and they showed the same thing, that if you can distinguish between this group of patients, which are the CML, we have the Ph positive ALL multilineage type, persistently BCR-ABL positive, and NGS will help you distinguish whether they are truly ongoing positive, or if they are NGS negative, perhaps their risk of relapse is not that high. So to summarize this part, BCR-ABL PCRs are still the gold standard. But in appropriate settings, NGS might be applied, especially if your BCR-ABL is consistently low-level positive and you are going to make a decision of an allogeneic transplant on a patient, and that's going to be resting on your BCR-ABL positivity. It's worthwhile exploring an NGS and knowing that the patient is truly positive. Now, what's the exact timing for making a decision making, and that's going to come in the slides which I'm looking at the transplant. Perhaps within 100 days is the right time to make that decision that your patient is MRD negative or not. So it's good to have a PCR-ABL on a patient at roughly around 100 days. And if they are not negative by that period of time, perhaps we need to have a bit of think about whether transplant is the pathway for those patients. The last part of my talk, what about allogenic transplant? Now, allogenic transplant has been the backbone, and this is based on all these trials showing these forest plots that you can see that the survival is better with overall survival is better with allogenic transplant. The disease-free survival is better with allogenic transplant. Of course, the TRM will be higher with allogenic transplant, but the relapse is lower with allogenic transplant as compared to just chemotherapy-based treatments. What are the numbers we are looking at, and why are we discussing this? The numbers we are looking at is showing that patients who move towards allogenic transplant, we can expect up to between the different studies, depending on whether they went MRD positive or MRD negative in a transplant, you can expect almost overall survival of between 60 to 67% in MRD negative group, or lower MRD survival in MRD positive group, yet you have some patients surviving. But we also know that transplant is associated with the risk of TRM, and so it's important that we identify the right patients who should go for a transplant. Clearly, it's established in the historical era when BCR-ABL was used that MRD positivity has a favorable impact on the outcome of transplant. We saw that with the NGS data also, that if you are NGS positive, at least that data was with Ph negative, that it has a favorable outcome on a favorable impact on the outcome of transplant. So I get back to this slide that I showed previously, just reminding that in the TKI chemotherapy era, this data clearly showing that patients that had a protocol transplant had a superior survival when they did a landmark relapse-free survival or overall survival in the patients. So benchmark of transplants clearly in patients who are fit. Now the question is, if when you're using TKI and you're using blinatumomab, what is the role of transplant in patients MRD negative? And again, especially in that. So let's look at what can all patients who are getting MRD negativity need a transplant. And this was a retrospective study done by Armin Gobardi out of Washington. 5 centers looked at the data retrospectively, looked at molecular remission that was achieved by day 90. Patients were treated with TKI and chemotherapy, range of TKIs, range of chemotherapy, limitations of a retrospective study. And then they looked at the patients who had a transplant. 98 of these patients, up to 30, had a transplant. 132 did not have a transplant. They find same molecular response as BCR-ABL negativity. This is across the whole group, and you can see that the curves, whatever, I think the best way to say is, if you don't have a transplant, the relapse risk is higher, but the TRM compensates for it, and your overall survivals are essentially the same. If you are robustly monitoring your patient, perhaps you can identify patients who are going to lose their molecular response and then move into transplant. They did a propensity analysis. They tried to match the patients and did a propensity analysis, and they found the same findings. There was overall survival was, the curves even went closer there, and the overall survival there was no clear impact. So there was an ongoing impact in relapse that they could see. And this is just putting in form of a table, multivariate analysis. The survivals are essentially going to be the same. You don't find a difference on the propensity analysis also, but you do find a risk in terms of relapse. So if you've got a robust monitoring system, if you're going to use a potent TKI, if you're going to throw in blend, the question now that we are asking is, and if the patient achieve MRD negativity, do the patients need a transplant? This gets me back to the DALBA data, and I alluded that 38% of the patients in DALBA had a front of transplant, and this is just to reflect that those patients had a transplant for a variety of reasons. They had MRD, didn't have MRD response, or had high risk genomics. Again, these are the same curves showing that you can the effect of genomic and poor biology still impacts if you use TKI and blinatumomab. So if you have an Icaros plus, perhaps it's going to put you in a risk in a situation where your risk of relapse is always going to be high. Now let's get back to the GMMR data, which was the more recent data, that was the ponatinib blend, and they presented the transplant data. And if you recall, I said they only had 11% of the patients who had a transplant in the experimental arm. That number did go up. So it went up to nearly 19%. So between that year and this year, they have now 19% who had a transplant. 15 of these were Icaros plus, MRD positive. At the end of induction, at the end of MRD, at the end of blend, or both these signatures. So the common region. Now, why these patients went undergo a transplant before exposure to blend, that was the physician's choice there, but these patients had a transplant. So in the era of blinatumomab, we know the DALBA had 38% of the patient transplant, 20% in patients in a subsequent, the ponatinib blend study, shorter follow-up, not as mature as 53 months as the DALBA, but at least a median follow-up of 2 years. We would be using BCR-ABL plus minus NGS, and the question is whether we've got other biomarkers that will tell us what to do. So I think the role of allogeneic transplant is evolving. We have to stringently monitor our patients based on BCR-ABL. Patients that need an NGS perhaps need an NGS. We have to pay more attention to the white cell count at presentation. This is now becoming one of the diseases where you have to do a more broader pH-like workup to find out whether they have a Icaros plus signature. And of course, you have to look at extramedullary disease and a patient's fitness to make a decision for transplant. But I'm just highlighting this the issue that is probably in a small font down there, but is important because these groups that are now reducing the incidence of transplant and are selecting groups of patients that would have a transplant based on biology or MRD positivity, these groups also keep the maintenance going on for a really long time. Ideally, they don't want to stop the maintenance if the patient is tolerating, or at least want to go for 5 years. So I think that caveat that you have to be able to monitor your patients on a long-term basis and give maintenance that long is extremely important. Summarizing, I've gone over time. I'm sorry. TKI, which is more efficacious, first line, I think the imatinib is really out, has to be dasatinib versus ponatinib. There is data on asciminib. It's not as mature, but the other imatinib is another drug that's coming on, and I think this field will keep on changing. If provided these drugs are safe for long-term use, we should consider using these drugs. Is chemotherapy or is how much chemotherapy is required? Now, this is where we've had a lot of discussion at my institution, and we've not decided that we are not going to completely abandon chemotherapy. We use a bit of dasatinib and a very low intensity chemotherapy to get a patient remission. But we said we think for CNS therapy or optimizing that CNS risk, we probably still give them 1 or 2 blocks of the hyper-CVAD, which has got cytarabine and high-dose methotrexate. Consolidation is blin plus TKI. In my institution, it's dasatinib. We use BCR-ABL very regularly on our patients, long-term, even in maintenance, and NGS as indicated. We give 15 intrathecals if you are using TKI blin, but as I mentioned, that we do use 1 or 2 cycles of systemic chemotherapy. And the indications for allogeneic transplant are evolving. As I pointed out, the newer indications are coming in, but one should be cognizant of the fact that you should be able to keep on monitoring your patients and should be able to keep the maintenance on going for a long time. So that's my last slide, and thanks for your attention, and I'm happy to take any questions. Thank you.
Thank you. Wonderful update. Learned a lot.
Yeah.
Many things clarified. So good. Before I ask our colleagues to ask questions, I have 2 questions. A word about inotuzumab and a word about CAR-T.
Okay. I'm glad you asked that question. So I dropped off the slides of inotuzumab. There's not a lot of data on inotuzumab in Ph+positive ALL. But ASH this year, there was a phase 2 study that was published with inotuzumab, that was presented with inotuzumab and dasatinib. The signal that they found was VOD. And so they had to go back and redesign the study. They were trying to give inotuzumab with dasatinib, but they started seeing VOD. So they changed their study design such that they temporarily separated out the exposure to dasatinib and inotuzumab. And they dropped the cycle of inotuzumab to just 1 cycle. Now, this is very limited numbers. I think there will be other groups that are going to push in this direction. I know the EVOL group is also pushing in the direction, and we have to just wait. The toxicity signal is the one that's worrying. Interestingly, this group that did the study, I think was Chicago, it was from Chicago. It was Wendy Stock's group that did that. They gave pomp and dasatinib. Now, why they were giving methotrexate and 6-mercaptopurine in maintenance is another question that perhaps is probably we would question that if you have a very targeted treatment, why not just give that? But that's what they were doing. So whether that added to the cumulative toxicity, we don't know. So we don't have that mature data. Now, CAR T cells is another very good question. And we certainly use CAR T cells in our patients who relapse Ph positive. If they've had exposure to 2 TKIs, they have relapsed, we use CAR T cells. The question is, I think you're trying to ask is, can we get the use upfront for these patients? Is that what you were hinting at?
Probably slightly different, whether CAR-T is a bridge to transplant or itself can be curative.
Okay, so that depends on the kind of CAR-T cells you're using.
Okay.
So this is a debate that keeps on going on in my hospital for a long. Okay, we have 2 products. We have Kymriah and we have Tecartus. Kymriah has got a 4-1BB co-stimulator. The persistence is very good. You can detect the CAR-T cells for almost 6 months. We are getting comfortable that we will not transplant on Kymriah, but we are very robust about monitoring our patients. We use the same 10⁻⁻⁶ NGS on our patients and monitor them. And if there is any signal, the other thing people look at is the B cell aplasia, and if they start losing the B cell aplasia, it becomes an indication to transplant, especially with Kymriah. but MRD is perhaps the strongest signal. If you look at the data from Tecartus, it's a bit patchy data, 55 patient study. It's difficult to tease out how long the responses are. The co-stimulatory domain is CD28. The persistence is not that long. If you speak to somebody in US, they will give Tecartus and they will try to transplant. But I guess we have to answer the resources that we ask for. So at this point of time, we are not doing it. But we are very robustly monitoring our patients for MRD, and we'll keep monitoring on Tecartus very long. There are two ways also, and there is a third CAR-T product that's Obe-cel, which is probably a more potent product that's not available to us. It's there in US, and whoever it's available to has tried to move from Rexucel or Tecartus to Obe-cel because it's got the 4-1BB co-stimulatory domain. The safety is very high, and perhaps the persistence better. So if you're using a CAR-T product where the persistence is good and the data is mature, we don't want to jump to a transplant. But I don't think we've got a clear idea with Rexucel. And I think that decision has to be made for each CAR-T product. We can't make it for a blanket decision.
Thank you. Dr. Krishna Kannan.
Good morning and good evening to you. Thank you for an excellent talk. I have a few practical questions. So in India, we don't have clear, easy access to ponatinib or blinatumab. It's quite expensive, and we have to, get it to the other market. And so for our strategy and for choosing patients for a transplant, is it right to say that we can choose patient cross plus or P53 mutation upfront in the NGS? Those would be the indication for a CR1 allotransplant. This will be my first question.
Yeah. So I think you're right. Those definitely will be there. But if you're not hitting a deep molecular response, that becomes an indication. Or if you're not hitting a timely molecular response, that would also become an indication. I always worry in my practice about patients that come with a high white cell count at diagnosis. I worry when they have AML, apart from if they've got a very favorable risk AML. If they're intermediate adverse, I would always worry about them. I also worry in Ph positive ALL based on what data we are seeing. Now, these are not large numbers, but these are some signals that we'll have to explore. And I think we'll have to all keep an eye out on how these patients go. Most likely, the patients who come with a high white cell count also don't achieve the MRD responses. And so you'll end up getting two possible reasons to consider your patients for a transplant.
Okay, the second question is regarding MRD. This NJS, which you alluded to, is the same as clonoSEQ?
Yes, it is clonoSEQ.
And for us, even the clonoSEQ may not be widely available. We have BCR-ABL.
And it's very expensive. It's very expensive, widely available. But look, I think it's going to be a matter of time. I think the way the field of molecular diagnostics and monitoring is moving, I'm sure people are going to start working out their own kits and study treatments. And it's a matter of keeping lookout for these. And if they are available and the results are reliable, to start using in practice. I guess the idea of presenting these things is not to shy away from these new technologies, because these are going to become a part and parcel and are going to help us in decision making.
Yeah, sure.
At the end of the day, we don't want to transplant everybody. We want to transplant the right patients. So this is what we are going to work with these technologies.
Okay. So if you do a BCR-ABL and they're negative, is there any role for doing a flow-based MRD? Or should we do both?
Again, a very good question. So my answer to your question is going to be that if you are a BCR-ABL, unless you've picked up something at diagnosis that tells you need to do a flow based on your patient. If there's something at diagnosis that tells you, then do two particular tests. If there is only a clear-cut Ph positive ALL, your BCR-ABL should be sensitive enough to tell you exactly what's going on.
Okay. And the last question, maybe I missed it. Is there a role for STAMP inhibitor in a Ph positive ALL?
There is a role. There's a very clearly a role. I just don't think the data is so mature that I should present. But in relapse refractory, there is data for the STAMP inhibitors to be used. Definitely. So if you've gone through your TKIs, and it's mainly in the relapse refractory, I haven't seen mature data for its upfront use to be saying that that's the direction we go in. The responses in CML are remarkable, but as you use more, you realize there are some patients who start failing STAMP inhibitors also. but the role in a Ph positive, which has got a more aggressive biology in upfront treatment, is not well established right now.
Thank you. Thank you so much.
Ashish, about the isoforms, majority of these will be P190, but if there are P210, that will be mandatory to transplant them?
We don't get that, but if you have a P10, what we will do is we will actually try to do a FISH on these patients to see are they truly a Ph positive ALL or they are CML blast crisis. So when we do a FISH, usually the labs can tell us whether the neutrophils are also showing or the myeloid are showing that signal. And if that's the case, then we will definitely start thinking of a transplant if it's a CML blast crisis in these patients.
Sure. Roshni, your questions?
Thank you for that detailed information and update. The first question is post-allo transplant, which TKI is the best and in what dose and how long?
Okay, good question. The data on post-transplants TKI is more based on recommendations. There is no randomized study to say, but I agree with you. We would do that in our practice. We will use a TKI in our practice. We tend to go to dasatinib as the preferred TKI, unless your patient has recovered quite poorly after transplant and you want to give them imatinib because the safety data is maximum imatinib. Introducing a maintenance treatment after transplant is not always easy. The patient can have graft versus host disease, can have CMV reactivations. All that will complicate the introduction of another drug for a patient. But we try to see by whether between day 60 or 100 we can introduce the drug. We are very active about monitoring that and seeing whether we need to dose reduce because you have patients on the tolerate it may have to quickly drop to 50 milligrams. The other issue with dasatinib is, and this was some data that was published some earlier, that when you use dasatinib and chemotherapy, there is a risk of CME reactivation. It's well documented, well established, and that risk can go slightly higher in a patient post-transplant. So these are things to be mindful of. You can use ponatinib post-transplant. Just have to be mindful that there are a lot of vascular fluxes that are already going on in a patient post-transplant. And if your patient is a vascular path, then ponatinib is perhaps not as safe. And if you're going to use it, then probably use it in the lowest dose of 15 milligrams.
And how long? Forever?
It's undefined. The expert recommendations say between 2 to 3 years that you should use for. But many a times, depending on the patient's tolerance, you might have to stop it earlier.
And the same issues with dasatinib comes when we give chemotherapy, induction, consolidation while waiting for transplant. We try to reduce the dose to 50 milligram and try to continue with the chemotherapy. But there may be some times where we need to stop.
Yeah.
So, I mean, what are those, what are those counts, the WBC counts, the platelet counts where we should just stop? The patient is having febrile neutropenia.
Yeah, if a patient is getting recurrently neutropenic, perhaps, and your patient is in a very good molecular remission, perhaps you should stop. I think the patient safety comes first. When we dasatinib and hypoxia we were using, we were giving 100 milligrams. We never went to 140 milligrams of dasatinib, 100 milligrams of dasatinib in the first cycle for 14 days only, and then letting the blood counts recover. And then we put our patients on 70 milligrams of dasatinib continuously. And we found that the tolerance was better. We never went to 100 milligrams when we were continuously dosing dasatinib. If you look at the US intergroup study, those were the numbers that they went on with also. They gave, when they were giving continuously dasatinib, they just give 70 milligrams of dasatinib to the patient. But you're quite right that if 70 milligrams is sufficient, then perhaps you won't frequently encounter those episodes of cytopenias, and you might be able to get through your chemotherapy with your patient.
And in young adults, should we use pediatric inspired protocols? Because, I mean, is there a difference in the biology between pediatrics and adults, or is it the better protocol or both?
A good question. It's a very good question, and look, something that I omitted out again from my talk. I had the slides for that. I don't do a lot of pediatric practice, but I can tell you what the pediatric protocols with TKI have clearly shown that you may not need a transplant if you give TKI. So there were two COX studies, one with imatinib, and there they a lot of subgroups, and they showed that when you give imatinib continuously, you may not need a transplant. It was the AALL02232 study, and then they came with the 234 or 343 study, where they used dasatinib again. Now, you have to look at the protocol very carefully. When they used dasatinib, they used it intermittently. They didn't use it continuously. When I deal with younger adults, and some of my colleagues initially were very enthusiastic about using pediatric inspired protocol, but in younger adults, and we are talking of people who are in their 20s and so on, we started running into severe hepatotoxicity when they were giving asparaginase and they were giving dasatinib. And so just for the safety of the patients, we actually abandoned using in the younger adults the pediatric inspired protocol. We went to hyper-CVAD and TKI. We made a choice that the TKI was the better of them, and we would. But if you are dealing with pediatrics, there are good two robust trials, one with imatinib and one with dasatinib on a pediatric inspired protocol that have clearly shown that you can significantly drop down the incidence of transplants.
And there is a patient who had he had CML. He was on dasatinib. Then he progressed to CML, lymphoid blast crisis. So he was salvaged with steroids, intrathecals, and ponatinib. He's a single child. He's 23-year-old, so no sibling donor. We put him to the donor registry, but we are still waiting. And in this process, the family is very reluctant to pursue this kind of to pursue it. So just continue ponatinib, or you keep on chasing them to say that you need to go through transplant.
Ideally, transplant should be the pathway, but you have to have a donor to do the transplant, right? We would, in this situation, if you have a CML lymphoid blast crisis, we would we do single antigen mismatch transplants also. So we would move in that direction for these patients. But you have to be comfortable doing that transplant. In absence of that, if the family is not agreeable, you're left with very robust monitoring of the time. If they're in a morphological and a molecular CR, then you probably continue on the best tolerable dose of ponatinib as long as you can on this patient. That's what you'll have to do.
Thank you so much.
Sure.
Thank you. Ashish, with ponatinib, do you use any kind of anti-thrombotic measures?
We don't, but we carefully screen. We carefully screen a patient. I don't think there is robust randomized data to tell us that is going to change the outcome. But it's the thing that everybody says is your patient selection has to be very good. And if you are dealing with an older patient, the moment they've hit a molecular remission, try them to get them to the lowest dose of ponatinib that you want to give. That's probably get them to 15 milligrams and keep going. The problem, I guess the issue is that some patients on ponatinib while responding will develop vascular issues, and I think we have to just monitor. We are fortunate enough that we do have some cardiologists who are pretty much interested in cardio oncology, and so they are pretty robust at taking these patients up and targeting their cardiovascular risk factors.
Thank you. Dr. Karthik?
Sir, good morning, sir. It's a very good talk. So I have one question, sir. What is the role of rituximab plus hyper-CVAD in general Ph negative and Ph positive BALL?
Okay. So let me target the Ph positive or Ph negative ALL first. So if your patient CD20 expressing, there is good data from the GRAL group based on a pediatric inspired that 16 to 18 doses of rituximab will improve the survival of the patient. The MRC group, what's the MRC? The UCAL ALL group did a trial where they used 4 doses. They could not find a clear benefit of using just 4 doses in the patient. So if you're going to use rituximab, it has to be those 16 to 18 doses. The data is with pediatric inspired. We have incorporated rituximab before Blin came in and front use. We were using it in those doses in a pediatric inspired and a hyper-CVAD protocols. Of course, the spanner in the works is now that you've got blinatumomab, is there any added advantage of using rituximab in your patients? And if you look at the E1910 data, there was and you look at the subgroup analysis, there are patients who got rituximab, that's the best data you have. But everyone's different, and some of my colleagues are very keen, they want to still use rituximab. So we have worked a way of getting some dose of rituximab if they really want to. Now, the reason we did that was because the Golden Gate study, which was the Amgen's continuous infusion study with low intensity treatment, did allow rituximab, and they allowed giving rituximab before the blin and then post blin also. So I think the reason we have continued in a very small group of patients based on physician preferences, we at least have the safety data, but we don't have very clear efficacy data that when you're using blin, rituximab is going to be helpful. The question is even more tricky in Ph+positive ALL. Where Ph+positive ALL, the UCAL study included a Ph+positive ALL, but they could not really show any benefit. So if you're using a TKI, you're going to use chemotherapy. It's difficult to quantify whether rituximab is going to really be adding any benefit to your patient. You also have to be cognizant that you're going to slightly increase the risk of infections in your patient based on what TKI you're using. So we don't use it in Ph+positive ALLs. Of course, we moved to blin in a Ph+positive ALL, so we don't have to use, and there is no data when we last looked up to tell us that Ph+positive ALLs, it would be helpful.
So one more question. So if I have a young fit patient whom I start ponatinib plus hypercivir and NGS MRD becomes negative, BCR-ABL becomes negative. So can I, like in the absence of high-risk mutation, so can I safely avoid transplant?
Yes, I think so. I think that's where the field is actually moving. If you don't have high-risk mutations, if you have got a robust MRD negativity within 100 days, there is data from that Armin Gobadi study retrospectively saying that although the relapse risk is slightly still higher if you don't transplant, the overall survival is the same. Now, the caveat to that are two. One, you should be able to monitor your patients very regularly, and you should be able to continue the ponatinib for a really long time. Because so that if your patient loses a bit of a response, you can go in and then go, transplant them. So in those caveats, I think that that's a reasonable approach, provided you can monitor and keep the TKI going on for a long time.
Can I apply the same for dasatinib as well, sir? Dasatinib plus hypercivir patient achieve deep MRD.
Yeah, it's applicable across dasatinib and ponatinib, I think. I would be a bit reluctant if it's imatinib you're using. I think we don't know that kind of data with imatinib, and we tend to worry that imatinib or controlling the patients may they may develop a few mutations and run into trouble. But if you're using dasatinib and ponatinib, I think that's a reasonable strategy.
Thank you.
Thank you, Dr. Karthik. Any discussion about asciminib?
So we haven't gone into it, but when we have patients, so we can access asciminib clearly for our CMLs after they've had 2 lines of treatment, and we put them on asciminib. We go to either 80 or 40 BD on asciminib. For the Ph positives, we have to write to the company and try to get access to asciminib. We've tried to do that for a couple of patients. We haven't been very successful, but these patients were multiply relapsed. So I think theoretically, it is an option, and if you have got a young patient who needs it, should be explored. Whether we have enough data to go up as asciminib as an upfront treatment, I don't think we have that data yet, sir.
Okay. A few questions. If anybody else has a question, please raise your hand. I'll take up some question from the chat box.
Sure.
So one is a question about BTKI in this situation. If there is a CNS disease and your standard treatment has failed, is there a role for BTKI?
So BTKI, sorry, I'm not good with acronyms for
Proton tyrosine.
Proton kinase, okay. No, not at all. No data with drugs like ibrutinib, acalabrutinib, or zanubrutinib. Not with Ph+positive ALL. I haven't seen any data coming there. Yeah. Okay. Sorry, I was expecting BTKI in this disease. Yeah.
Yeah. The next question is, in the era of ponatinib plus blina, does this become the standard of care for all patients?
I think so. If you've got access to it now, remember, ponatinib blin is what we know from this data from the phase 3 is more of a consolidation. So you still have to get your patient into some sort of remission. And if you can consolidate them with ponatinib and blin, and I think if you were to marry up the data between the GMMR group and the E1910, you're looking at least 4 cycles of blin that probably you want to give your patient. And then you want to continue your patient on ponatinib maintenance for perhaps as long as you can continue. If the financially there are no restrictions, patient is happy to tolerate, is understanding, you can deliver 4 cycles of blin. I think it's the strategy that will become the gold standard every day. Of course, I do acknowledge that giving blin is not the easiest thing. It's a cumbersome treatment to give. So you have to have a very understanding patient. You have to have the facilities that you should be able to give blin. This field will quite radically change if the newer immunotherapies come in. The ones that the patient comes in and gets an infusion every fortnight and our infusion and goes away. That's a completely different case, and that will consolidate this whole strategy of using ponatinib and blinatumomab.
Sure. The next question is, do you check all your newly diagnosed ALL patient for 315I mutation?
No, we don't do a baseline. I don't think a molecular lab is that friendly that they will do it 315I for us on the baseline. They will do a BCR-ABL, we'll run an NGS on our patients, but if we start getting signals, then they are more than happy to run it for us and try to do it. I guess if you run an NGS, you can identify and pick it up if you push them quite hard, but we usually don't ask for that. We ask for that if we think there's an indication developing in our patients.
The next question is about mixed phenotype acute leukemia or biphenotypic ALL with Ph positivity. So is it still okay to use blina, TKI, or this will be all chemo-based approach?
It's a good question, and the studies haven't distinguished into that. And one of the common causes of MPAL is actually a BCR-ABL positive leukemia. What we have tried to do in these circumstances, that if you're going to a targeted treatment, you want, and this is one circumstance where you want to do a flow cytometry to see what's happening to your clones. Because if your clones are there still, and it's a predominant myeloid clone that you're still dealing with, you would really question whether blin is going to do anything for your patient. So I think you have to get guided by what you find in your results. I don't think it would be absolutely wrong to consider blin, but if you're seeing a myeloid clone hanging around there, you really question whether you're going to truly eradicate the disease by this strategy.
Thank you. What's your management of isolated CNS relapse?
Yeah, it's the most vexing problem. I can tell you that it's the most difficult problem. You keep on getting intrathecals. We get a Omaya put in and we give intrathecals. If you're going to use the TKI, we think there is some benefit with dasatinib because there might be some CNS penetrance with the dasatinib. If your patient is fit, you can give some CNS directed chemotherapy, systemic chemotherapy. Of course, radiation is there on cards because if you've got recurrent CNS relapses happening, you have to think of radiation. Cranial radiation is easy to administer, but will cause later on cognitive problems in your patients. Craniospinal radiation is very difficult because patients may be rendered aplastic, and then unless you've got cells to actually give them back, that's going to be a different proposition. So those are the things that we would think about in our patients actually.
That's the last question. And anybody from the audience here? So no one. Okay. So Ashish, thank you so much.
Sure. Thanks a lot, sir. Thank you.
Enjoyed. We learned. You spared your time. Beautiful presentation. Real update.
Thank you. Thanks a lot, sir.
Thank you so much. And we will keep bothering you. Thank you.
Thank you. Always a pleasure.
Bye, Ashish. Bye. And bye to everybody.